All right, so it is June 3rd at about 11:05. So we're getting started with the study session today. I just want to kind of cover what's going to happen over the next couple weeks so that you have an idea for my study sessions. What I have planned over the next couple weeks, because we have June 10th, June 17th, June 24th, and July 1st left as kind of the last couple days. I have June 10th now scheduled. So next week, I'm going to go over pharmacology. So we're going to hit pharmacology heavy next week. And then June 17th, I'm going to go over pathology. So just in general pathophysiology. So looking at kind of gamut of diseases that you're going to see on the boards. On June 24th, I'm going to look at research and specifically just kind of recovering alpha values, p-values, all those fun stuff that everyone loves for research. I see Jason just rolling his eyes at me. And then on July 1st, which is the week before the boards are kind of slated to start, what I have scheduled for that is I'm going to do a full neuroanatomy review. So we're going to have a review where we just go back through the dermatomes, the myotomes, the nerves that innervate muscles, stuff like that, just to get you kind of that final touch up on neuroanatomy. Because like I said before, if you can do neuroanatomy for the most part, you can actually answer most of your questions. So that's kind of my path for the next couple of weeks. I know that the courses for the other thing, PT final is a little different, but those are what I'm going to go over the next 4 weeks. And then obviously, if anyone sends me anything, we'll go over that too. I apologize if anyone has contacted me this week. It has been a nightmare because we are going through ABHES reaccreditation right now. And yeah, that's scary. And then also I found out on Thursday that the CAPD accreditation meeting was, and evidently that was supposed to attend that and I didn't know. So now I'm dealing with CAPDs being mad at me. So it's loads of fun, I must say. That's the absolute best way I can say it. It's not fun. So I have a non-systems review today. And let me kind of bring it up here. And let's see if I can get it working better this week than I got last week. All right, now let me share my screen. And there it is. Oh, having two screens again is so nice. I love traveling, but I get spoiled by having my technology at home. I'm just saying. I will say that was a nice break getting out and not having any like noise or fire police or anything out around me, or police or anything. All right, can we all see the Slido? I'm assuming. Yes. I see some heads. Okay, good. Are you guys able to join it? Is it letting you? All right, there you go. Okay, seeing people. Oh, okay, that's fine, bro. I am in no rush. I'm American, not Russian. I have a feeling next week, I know there's only a few of you here today. I have a feeling next week, once they see that it's going to be pharmacology, I have a feeling we'll have more people showing up next week. Because that seems to be the one that's scaring everybody. All right. Give Brooke just a few more moments to find her phone. She lost her phone. I also can't confirm this, but because I have to go back and rewatch the video. But the class on Tuesday, I think she might have gotten specificity and sensitivity reversed. I I was a little confused watching her because she was trying to say that specificities was for ruling out conditions or confirming conditions weren't the problem. I just think she got those reversed when she was talking about them.
Yeah, she was saying, oh, let me see my notes. I was confused by that too. I don't remember what but like sensitivity was a true positive and specificity is a true negative.
Yeah, that was, yes.
So is that reversed or is that the way it is?
So just remember the spin and snout.
That's all I'm gonna do. Yeah.
Yes, that's 100% honest, Jason. Just remember the spin and snout. I don't like, I've always hated the way of saying it's a true this or a true that. Spin and snout is the easiest way to just remember it, right? So a specific test with a positive result, you have the condition, right? And then a sensitive test with a negative result, you don't.
Yeah, that's the easiest way for me to do it. I was confused by the way she was explaining it too.
And they're not going to be talking about true positive and true negatives on your boards. They're just going to ask, they'll say, here is the McKeever test for aggravation, which has which of the following levels would be best for ruling in the condition. And it'll give you a bunch of specificity and sensitivity numbers. And obviously it's ruled in, you want a high specificity.
Okay, so they'll give us the numbers?
They'll give you the numbers, yes.
We're not going to have to know, because I remember when you were teaching us this, you gave us, I have like the list of like.
Yeah, I gave you all those numbers. I gave you those for the clinic primarily.
Okay, I was like, I can't memorize every single one of those.
No, they're not going to. So they'll say something, if they're talking a specific test, like say they say the Thomas test.
Okay.
They'll say the Thomas test has a specificity of 0.9 and a sensitivity of 0.6. It is best used to, and it'll be ruled in a condition.
All right, that's good. That's easy.
Yeah. Or they might, like said, give you a list of your choices might be a list of numbers where you have to pick whether it's the best to rule in, rule out, or for both. Right? If you want something that's a really good test, it would have a high specificity and a high sensitivity.
Oh, okay.
Right. We'll give a couple more people a chance to get in. I will say that I'm on mute on this call. I'm on the accreditation for continuing education committee call, sitting here on my tablet in front of me, and they're giving like the classes to who's approved as a continuing education class, who's not. Man, I'm just the way they do it is just not the way I would do it. I'm just going to say that. That's all I got to say. All right, I'll give a couple seconds here in case Alex wants to jump on the Slido while we're doing it. And let me see. And just Alex, just since you joined a little bit late here, I just wanted to let you know. So my schedule for the next couple visits with me on June 10th, which is next Friday, I'm going to be reviewing pharmacology. On June 17th, I'm going to be reviewing pathology. So in general, most diseases, most of the ones you're going to encounter, right? I'm not going to cover something like some obscure African disease that we'll never see. Right, or something like that, or like, I don't know, quasi-core disease or something like that. And then on June 24th, I'm going to cover research, and I kind of made Jason cringe when I said we're going to go over alpha values, p values, and all those fun things. And then right before your boards on July 1st, which is the weekend before July 4th, I'm going to cover neuroanatomy, where we just go back through and review all the nerves, the dermatomes, the myotomes, all that to kind of get you prepared prior to doing that. So that's kind of what's going on. All right, I got you guys enough of you in here, the Slido. So I'm going to start it again. This is a non-systems review. Let me bring this up in full screen. Let's see if it's going to work this week. We'll see if I don't have any technical problems. If not, I got my phone right here, so I'm ready. I'm gonna have to have my phone here. Figures. Very good, right? Very, very good. So the right answer here obviously is BNR. Where would you find all the other things? Duty cycle, frequency, intensity.
Like on the screen?
Yeah, on the machine itself. Exactly. Yeah. Right. And what would decide those numbers for duty cycle, frequency, intensity? Well, obviously, go ahead. I'm sorry.
What you're trying to treat?
Yeah, what you're trying to treat. Exactly. Yeah. Or even more importantly, maybe just the PT in general, right? If they want something specific. All right. Good job. I'm happy. That's the first one. Okay. Do you have a question?
I was just gonna say duty cycle is when that means the on and off time, right? Like only 20% of the waves are getting in there. So you would want it higher for more thermal effect, right?
Yes. So continuous is thermal, percentages for, always remember that continuous is for heating pulse, or percentages is for what?
Healing.
Healing. Good. There you go. Yep. And then the intensity is how much energy is being delivered by the ultrasound, right? That's in the watts per centimeter squared. And then what was the other one I had on there? My brain just completely.
Frequency.
Frequency is the determination of the depth, right? What are our two choices for frequency?
1 megahertz and 3 megahertz.
Yeah, right. That's it. That's all that is to ultrasound. You got it. All right, let's get ready for the next one. Here it comes. Okay, so first of all, just going through this, does the NMES matter at all at this point, really? No. The NMES is just there kind of as that good old red herring, right? This is literally just asking you, what is the most beneficial frequency of treatment for a patient that's got a knee meniscectomy? Right? And the most beneficial at this point, ideally, would be 3 times per week, right? And the major thing here is that because 4 weeks are probably already at what stage of therapy? They're in outpatient therapy. They better not be in the hospital at 4 weeks. They've got some major problems at that point. Oh, now my stuff at the bottom finally showed up. That's great. Thanks. All right. Next question. All right. So good. You guys got down between the top 2, right? So the key thing here is we don't know whether this is a patient we've seen for a long period of time or a short period of time, right? Because it just says we're going to do lumbar traction. The main thing is decrease muscle spasm, right? Now, what if it said to separate the facet joints, which would be the best answer then?
50%.
50%. Yeah. right? And the main reason 25% is best for muscle spasm is think of the force that 50% is going to give, and that's going to cause the muscles to do what? If you're pulling on them that hard. They've already got muscle spasm, it's going to cause them to spasm worse, right? Because you're now yanking on them. It's like doing an overstretch on a spastic muscle, right? So 25% is the best answer there. Could you go up to 50% though? Probably. I wouldn't recommend it.
Wellness versus my physical wellness, K, and the one that's more psychosocial, so it could go under there as well. But I think if it was approved last summer, I'm not critical, and there is one that I can put it under.
All right, let's see what we got here. Dr. Reskin was contacting me. Yes, good. I always like the number 2 answer, the modify patient's present treatment program and minimize the effect of alcohol. That's basically saying, make him run on the treadmill till the alcohol's out of the system. Yeah, we definitely don't want the 4th option, instruct the patient to leave the clinic. Why would we not want that?
Because they're going to drive themselves.
Yeah, they're going to leave and drive themselves, right? Yeah, and honestly, if the patient would just leave on their own, what would be the best option to do at that point? No, it's not one of these. So say the patient just decided he got mad at you and left the clinic. What should you probably do?
All the time.
Yeah, call the police. Yeah. Because it's better to get him off the road than leave him driving around, especially 6 to 10 alcoholic. I love, I'm trying 6 to 10, which probably means 14. Just saying. Look at Brooke at the top there. Okay. First of all, let me ask you the question. That first sentence, does it matter? Absolutely not. That's just there because now you're going, wait, what was vital capacity again? What was expiratory volume? Oh God, I'm freaking out, right? All it's asking is, what's the job of the IRB, right? And the IRB's job primarily is to ensure the rights of the research subjects are protected. That's their main job. And by process, okay, what does IRB stand for? Good. Does anyone remember?
Like internal review board or?
Yep, internal review board. Yeah, good. Every research hospital, college, whatever that does research in general has an IRB. And they are the bane of your existence if you're doing research, because literally they will send your research back to you if you have a "the" out of place. They're like, nope, this comma is out of place. Please send back in 2 weeks. Oh, son of a. But the main job is to protect the rights of the patients, right? The subjects that are there. Now, by doing so, it also would protect the hospital from litigation, right? But its main job is to protect the rights of the subjects. All right. Y'all better get this one right. Good. Yes. If you do enough ice that you get paraplegia. Wait, that's wrong. You guys are right. What the hell? All right, I gotta fix that one. You guys are correct. I am wrong on my answer. I don't know how that happened. Yes, paraplegia is the right answer. So yes, give yourself a point if you didn't get it. Because if you do ice massage to get somebody paraplegic, then you've got problems. What's the abbreviation to remember for that again? C-band. Good. Yeah, please ignore my mistaken clicking. I think it's because I moved this question higher up. It got screwed up. I'm just leaving the meeting. It's no point. So Brooke would have perfect, I'm sure, at this point, if I didn't screw up. All right, so a couple different answers here picked. So first job is to ask the patient's mother to go to the waiting room. Now, would we document the mother's comment in the medical record? Maybe. It depends upon what your clinic's policy is on it. Some of the clinics have a specific place where they document stuff like that that's not on the medical record itself. Because once it's in the medical record, that mother now has what to it? Access to it. And she can see that you documented it, right? So sometimes it is, sometimes it's not. You definitely don't want to just be like right in the middle of the treatment session, the mom's being mean and be like the kid, so is your mom verbally abusive to you? That's gonna send your treatment session in the right path there, right?
My problem with this one is, as a 35-year-old male, I never want to be alone with a 16-year-old child.
Yeah, so right. At that point, probably what I would do at that point is ask the mother to return and see if I can get one of the other members of the clinic to kind of stay nearby. Right?
Oh, okay, yeah.
Yeah. And honestly, for the most part, what I'll do at that point is I may just send the mother out to the waiting room and go to the open treatment area. Right? After I kind of calm the patient down, because probably the patient's going to be pretty livid, I'm guessing, right? Or just be like, mother, come on. It's going to be just like Brooke is every day. No, just kidding. And I've treated 16-year-olds by myself, but you're right. There is that concern, Jason, that you're always like, especially nowadays. Yeah, I was gonna say, I took this one from the modalities book. Now that I look at it, I don't like it. I'm gonna give both of you guys credit, whoever picked that, because the best answer would be hertz there, but pulses per second is hertz. So I don't like that question in general. Now that after I put it in, I borrowed a couple from the modalities book just in case. And now that I see that, I really don't like that. So technically both of those would be correct because pulses per second is hertz. That's okay. That's fine. All right, so we're all over the place here. Let's see if anyone got this right. Let's see who waves and smiles. High volt is the best for wound care treatment. Now, there's a way that you could answer this if you didn't know the answer. What are pre-mod, interferential, and TENS all used for?
Pain.
Pain. Yeah. So pre-mod is nothing more than interferential. Interferential is used for pain, right? Could also be used for swelling as well, technically. But TENS is definitely a pain modality. So high volt is the best option there. Good, 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 good. I'd be really impressed if you could discontinue a halo. I mean, that takes some hardware. You'd have to get out the drills, take the screws out of their head, pull the pins out. That'd be impressive. But yeah, so you're gonna put a liner in there, right? And most of the liners are gonna be some form of like a cotton or a wool that'll protect that area. Who else should you notify? Don't say your PT because you're gonna know by the notes.
The surgeon.
Yeah. Yeah, right. The surgeon, the clinician, whoever's in charge of the patient's halo, right? And if they have a specific orthotist that's fixing their halo, right? Like in town here, specifically, Orthopedics in Motion does almost all the halos in town. Their company comes in and puts the halos on the patients for the doctors. The doctors don't even do it. That is their job. They come in, put the halos on them. They do everything. They do all the adjustments on the halos. The patients, actually, they go to the patient's house for the most part. So at that point, I would notify, in our town, I would notify them saying, hey, patient's got some breakdown occurring. Now, skin irritation under the chin indicates they have what level pressure injury?
1.
Level 1, yeah. Right, as soon as it's irritation, we're at a level 1. And hopefully we can prevent it from getting to level 2, 3, and 4, because I'm sure they like their chin. All right, let's see how we did here. Good. Muscle tightness would be an indication for what?
Heat.
Heat. Good. Is spasticity indicated for cryotherapy?
It can be, which is really weird.
Well, it seems weird, right? But the logic of it makes sense because the ice, the cold temperature is going to do what to the conduction volume of the nerves?
It's going to slow it down.
It's going to slow it down, right? And so by slowing that down, that reduces the spasticity. Because the spasticity, if I'm spastic, my problem is my muscles, the nerve is firing way too much. And so if I can use the cold to slow it down, it'll sometimes relieve the spasticity. But it is weird. You're correct, Riley. Brooks, Max, I messed up a few of those questions. I know everyone's mad because this is a math question. This is McKeever. You said no math. All right. Let me show you the easy way of solving this one. What's 3 times 25?
75.
75. Yep. Right. So the way you'd solve this is by taking 0.3 times 250. But in reality, if you just knock both zeros off, 3 times 25 is 75. There's your answer. That's the extent of your math. It's not going to be anything like your patient is 12.7% weight bearing and they weigh 317 pounds. What is the weight bearing amount? They're going to be pretty simple math problems like that. And hopefully, I'm glad none of you picked 100 or 175. I'm glad for that. That's okay, Alex. That's why we do this, right? That's why we do it for 45 seconds to get your brain going. Oh, there's the same answer from somewhere else. Almost. Okay, we're all over the place. Okay, so let's go through. What are some key items about this question?
Direct current.
Okay, who picked direct? What's direct current?
And I'm sorry, like electrical stimulation. So
Okay.
I would think direct current.
Okay.
Since it says while present in the clinic.
Okay, good. There's one of your keys, right? So that rules out which one? Probably.
Tens.
TENS. Good, because TENS is typically an at-home treatment, right? Okay, so that one gets ruled out. We obviously have electrical stimulation, right? And then we have pain modulation, right? Pain modulation is one of those, so we got to rule out. Yeah, there we go. Pain modulation is one of them, right? So the other thing I'm looking at is lateral ankle sprain. Yes, there we go, Anthony, right? Lateral ankle sprain. Why is that important? Why would the area be important? Because it's what? Small. Think of the size of your ankle compared to like your low back, your calves, or stuff like that. The most appropriate would be pre-mod. Now, It's a little bit of a trick question here. A little bit. And there's a reason for that. So pre-mod is interferential, right? But what's the specific type of pre-mod? What's pre-mod? Why is pre-mod different?
Is it just smaller?
Yes, what he uses, how many pads?
1 probably.
He uses 2. Right? He uses versus interferential, he uses how many? 4. Yeah. Right? And what pre-mod does is it literally splits the pad in half. So it creates its own cross current like you would normally get. Now, could direct current be used for this? Sure, but it's going to cause them more pain. So at this point, we don't know if it's chronic or acute. They didn't say that specifically in this question. At that point, we have to assume that they're not in the chronic phase.
So where else would we use pre-mod?
Well, we could use it on the wrist.
Okay, like the elbow.
Elbow. Yep. I've used it on the neck too, because sometimes putting 4 pads on the neck can be really a pain in the butt.
Okay.
Right? Or suboccipital region would be a good area to put it, right? So usually the smaller areas are going to be pre-mod. Hand, if you're doing hand therapy on somebody, like somebody's got carpal tunnel syndrome, especially something like that, or a what am I thinking? Trigger finger. There we go. Something to that effect.
Pre-mod is just inferential but smaller.
Smaller. Yep, that's all it is.
And so when would
And I have this direct impression that that wasn't probably covered in your modalities class. Jason's like, nope.
Nope.
And when should we use direct current?
So direct current, how many of you guys have seen somebody use direct current? Any of you? So direct current looks like a little gun. So the direct current has a dispersive pad that you put under the patient, and then a little, like, the best way I can put it is a gun. It's that little pointer that comes off of it. And you use it to stimulate directly on the motor, the motor plate. So it can be used for 2 things. It can be used for purely denervated muscles to try to stimulate them a little bit for recovery. The other thing it can be used for is for pain in the chronic level, because it's going to cause what? It's literally going to cause that muscle to just spasm out, and it's going to cause a opiate release. You can also use direct current on wound care if I don't have a machine. Like I could use that if I'm doing edema control on wound care, but that's a pretty rare use case of it. And it's one that's not going to be on the boards, because that's more of a, you went to a wound care conference and learned how to use it type question. That's okay. That's why I have these questions. So now I know I need to add pre-mod to the class next semester. Okay. So remember, the key here is most appropriate, especially in the current state that we're in. Mount the mask. So where's my kid at? When it's talking mask,
I picked that one hoping that's what you were talking about. And I was like,
Yep.
oh no, if he's talking about like a regular mask, I got that one wrong.
no, and I highly recommend, if you guys can, just picking one of these up and carrying them with you, because if your clinic should have them, but it keeps a barrier in case you need for your patient. All it is a mask you put over their face, and it allows you to breathe into them. Your clinic should carry these, but these are like $12 on Amazon or something like that. Now, what if the mask isn't there? Then mouth to mouth is the most appropriate, right? But mouth to mask is the most appropriate. What if I changed that and said it was a 5-year-old child?
Mouth to nose.
Mouth to what? Nope. Mouth to mouth and nose. Yes.
Sorry, mouth and
Yep.
nose.
Yes. Right. So, and that stops at about 8 to 10, because at that point their nose and mouths are so far apart, you'd have to have a really big mouth to get over both of them. They're like, come here, child. Oh. But yes, for a child, we definitely want to get over mouth and nose, and mainly there. And out of all of this, if I was writing this question, it says which rescue breathing is rescue breathing as important as compressions? No, correct, Jason. Compressions are the most important out of all of it, because yes, they can survive. They've got latent oxygen in their lungs, right? So if you at least keep the blood flowing, it's at least exchanging the gases, right? Even if they're not breathing, it's more important to get that compression done. That's why they changed. Like when I went through school back in the days, it was the ABC of CPR or CPR. So it's airway clearance, breathing, and compressions. What is it now? Do you remember what the 3 abbreviation is now? Compressions, CAB. Compressions, clearance of airway, and then breathing. Why would you want to clear the airway before you provide a rescue breath?
So the breath can get in.
Yeah, right? You've got them choking on a huge chunk of steak and you go to give them a rescue breath, you're not going to get anywhere. It's like blowing up a balloon that doesn't have anything. But yeah, these masks are, I mean, like I said, they're really nice because literally you just snap this little top on here and you pop it out. I might have to replace mine. Mine's pretty stiff. And it has a mark on it for the nose. You put that over the nose, slap it on them, and then you can breathe right into this. And then you also don't get, and the nice part about it, if you look here, it's got a filter. What's that keep from getting in your mouth?
Spit.
Yeah, there's spit.
I was gonna say the patient.
The patient, yeah. Now, you may get that patient that really wants a mouth-to-mouth resuscitation, but that's not the patient you want to treat. I think I'm passing out. I need mouth-to-mouth. And Brooke's like, die. Just kidding. All right, let's see here. So I know 3 to 5 sounds like it would get most people numb, but 5 to 10 is by the book. Right? So remember that for all other modalities, so hot pack, cold pack, what's the time? Even traction.
15 minutes?
15 to close?
20.
30.
15 to 20, yeah. Yeah, 15 to 20 is kind of your golden rule for all the other modalities, right? And then ice massage is 5 to 10. It's the only oddball out. Now, could you do 15 to 20? Sure, you could. But I don't think they're going to be very happy with you at that point. And yes, it may be that your patient gets numb at 5 minutes. The better answer here would be until numb. Because if they got numb at 5 minutes, you're done because you've achieved what you wanted. Right? But 5 to 10 is the standard for ice massage. You guys are getting faster at answering these questions. Okay, first of all, I'll say for the first 3 answers, ew. That's all I gotta say. Right? The standard is, doesn't matter if it's for wound care or where it's for, I don't know, edema control or for muscle tension, if for doing a hot whirlpool. Remember that a whirlpool isn't what you think. It's not the type of whirlpool like you guys get at the Holiday Inn where you get in it and you're like, oh, this feels good, right? A whirlpool is literally a tub about, yay big, right? And so it needs to be changed between every patient, which is the pain in the butt, which is why we don't do whirlpool treatments anymore, because unless it is wound care, that's about the only time I do whirlpool anymore. Because literally it takes you 15 to 20 minutes to clean the whirlpool between treatments. So, yeah, if you're cleaning it once a week, that's a lot of gunk that's going to be in there. Skin cells and gunk and slough. Let's see if I threw anyone for a loop here. No, I didn't. I didn't get any of you. Oh, darn. Yes, 1 to 2 inches is a standard layer of protection. What about layers?
6 to 8,
Unless what?
unless they're lying on their back and prone.
Okay, and then it's what?
8 to 10.
Good. Yeah. Right. I was hoping this question wouldn't throw anyone, because I hope you looked at this and went, well, 1 to 2 meters is way out. They're talking 3 to 6 feet between the hot back and the patient. And then 1 to 2 feet still definitely out, right? So you're down to 1 to 2 centimeters and 1 to 2 inches, and 1 to 2 centimeters is, that big. That's definitely not. Now that may be Walmart towel layers, but it's definitely not needed for the patient. Good. Does diagnosis matter here? Nope. Just asking how many dips, and 6 to 10 is the standard dips. Everyone enjoyed the paraffin class, Alex. that was like the other group, the new cohort's like, so when do we learn paraffin? I heard that's a really good class. They're not enjoying the bones. I'll say that right now. The brand new cohort, they are just not enjoying the bones at all. Okay, good. We got down to probably the two best answers. I appreciate that. Now, so let's go through the thing. What are we going for? Heating or healing?
Healing.
Healing.
Healing, right? Because we have tear. Good, right? Is the ACL deep or shallow?
Shallow.
It's shallow, right? So that means we want how many megahertz?
1.
3.
I keep
Remember? Yep.
confused with like
Oh no.
Oh no. Okay, so remember, with frequency, it's inversely proportional to what you're doing. It means it's the opposite. So if you're deeper, you want a lower number in frequency. And the way I remember that, because I'm a nerd, and the way I remember it is that, how many of you guys all have routers at home for your Wi-Fi, right? I assume that you can get Wi-Fi everywhere through your house. Your router has 2 bands on it. It has a 2.4 gigahertz and a 5 gigahertz. The 5 gigahertz gives you the fastest transmission, but it doesn't go as far in your house because the walls block it. Whereas the 2.4 goes farther because it can go through the walls. So that's kind of one of the things I remember for ultrasound is that the lower the megahertz, the deeper it goes, the more penetration. That's okay. And then just remember that in a small area, your intensity always starts at 0.5. So if you have a small treatment area, it always starts at 0.5. Does that make sense? Yes, Brooke.
I keep getting confused with like the superficial structures versus deep, because when we did like the sacroiliac one, I guess it was deeper, and I could have sworn I'm like, I don't know, but I don't know.
So, Anthony, ACL wouldn't be deep. What would be deep? Which ligament? Oh, meniscus maybe. Okay, good. That's actually not a bad answer. But which ligament? PCL would be deep. Yeah. Remember, the ACL attaches to the anterior surface of the tibia, right? It's to keep it from translating anteriorly. So it's really, when it tears, it kind of is right here is where it tears, right? But the PCL would be the one definitely that would be the deep one of them, right?
So everything but the PCL would be superficial.
In the knee, yes, absolutely. And actually in the elbow, all of them are superficial.
And what about ankle?
Ankle would be all superficial.
All right.
Yes, so PCL would be 1 megahertz. Yes, you're right, Alex. Yes, PCL would be our 1 megahertz deal. So let's talk the sacroiliac joint. I didn't like that question. And here's why I didn't like that question. If I'm doing ultrasound on you, Brooke, I'm probably going to do 3 megahertz. If you were doing that ultrasound on me, you'd probably do, or I do 3 megahertz for you. If you're doing it on me, I'd probably do 1 megahertz, because I'm just saying I got a little bit more of a badonkadonk back there than you have. Right? And so you'd have to get through more tissue. So I didn't totally like that. I think that could have been a better question than the one that's there. I understood her reasoning for it. It made sense, but at the same time, I think these are the ones you're going to get. You're going to get the elbow, the knee, or the ankle when it's talking superficial, or maybe the wrist, right? They may ask you, your patient has a carpal tunnel nerve injury. Which of the following ultrasound would be most appropriate? At that point, you know the wrist is superficial, right? And honestly, I don't like doing ultrasound on the carpal tunnel very often because there's so many nerves in there that can get irritated that it's just, I don't like doing it. I'd rather do laser or something like that. So 3 megahertz, 50% duty cycle. Bicipital tendinosynovitis, yes, absolutely, Alex. That would be superficial, unless it says you've got a bodybuilder, Alex, which I don't think there'll be a specific question about that. But in general, yes, it would be superficial. Supraspinatus tendon would be deep, because that's under the AC joint, right? Because you're going to have to get under. It's going to be kind of, you're going to be doing the ultrasound kind of in this area here, and you have to shoot it back into that area. Let's think some other ones that might be. I'm trying to think if there's any others that I would think of. No, like Achilles tendon would be shallow. Most of them.
I
Good.
got one practice question about the triceps muscle belly, and I picked deep, so, and I got it right.
I mean, I guess I could see that because the tricep muscle belly is large, I guess would be probably the
Yeah.
reason.
That one
Um,
confused me because I was like, it's kind of superficial, but it's
Yeah.
decently large muscle, but I got it right picking deep, so,
Yeah, I mean, for most muscles, I honestly pick 1 megahertz
yeah.
just
If it's like
because,
the muscle belly,
yeah, just because I find that it heats it up faster,
okay.
right? Because when, again, the other side effect is if you're doing continuous, 1 megahertz heats up faster than 3 megahertz. So that's why it's kind of, and that's a clinical reasoning idea, but I still probably would have had 3 megahertz if it was my test, but whatever. We'll go with what they say. In that case, they're probably not, in that case, if it's talking about the muscle belly, they're probably not going to go with talking about the megahertz. They're probably asking whether it's continuous or pulsed. That's probably going to be the major question. All right, now that I made people mad. A lot of E-stim questions. It's almost like I knew you didn't get much E-stim. That reminds me, I'm going to upload last week's lesson. I didn't do that yet. Totally forgot when I came back. Yeah, my fault. I just didn't get it up. I totally forgot because I was up in the mountains and I got distracted by moose. Honestly, as soon as you guys were done with my lesson, there are literally 5 moose out on the deck eating away at the trees. It was great. Or not moose, elk. I'm sorry, elk. Same thing.
I was about to ask, where did you go?
Yeah, mesas, yes. I guess elk is as or yeah, elk. I mean, they're the same basic thing. I'm just saying. They really are. MES for the answer. Okay, good. That would be the right answer, which is the form of NMES voltage. So again, this is another question looking at this, that the other 3 are for Jason, say it again. Pain, yeah. Right. Yeah, I did this on purpose. So I was testing to see if you guys, so the 2 main types of FES or NMES, whichever way you want to call it, right? Functional electronic stimulation, neuromuscular electronic stimulation. They same terms, just different sides of the coin. The 2 main types are Russian and VMS. So, and there's a difference between the 2. Russian is amplitude modulated. So Russian is going to, when you put Russian down on your chart, you're going to put it as at 50 milliamps, 65 milliamps, or something like that. So that means you're adjusting the current. Remember, because milliamps are is the unit of current. VMS is voltage modulated stimulation. That means it's not current that's adjusted now, it's the voltage that's adjusted. The major difference between the 2 is VMS is less bitey. It doesn't sting as much, right? Now, it still doesn't feel great. It's not like it's like, ooh, that feels good. No, it still doesn't feel good, but it's less bitey. Like VMS is mainly used in older folk and kids, whereas Russian is typically in that adult range. If I try to put Russian on a kid, the kid's going to run away from me because it's just the amplitude causes that. You guys all felt it when you put Russian on, right? You felt that just intense like contraction effect. Voltage causes the ramp to be a little less intense. And so it's a more sustained contraction with VMS and a little less bitey, but Russian is better for the re-education. So those are the 2 main types of NMES, is voltage, VMS, and Russian. Does that make sense? Does that clear it up? Okay, I see some head nods. All right, well, I got a few more. I'm gonna grab my laptop real quick because that's where the last week's lesson is. All right. So what I see here is we don't know the golden rule of iontophoresis. Brooke's like, nope, no idea.
Not at all.
Okay. And I put this on here. So first of all, I put this on here to freak you out. Okay. Second is because there's one golden rule about iontophoresis. The golden rule of treatment for iontophoresis is 40 milliamp minutes. So let me get my little drawer up here. It's written like this: 40 milliamp minutes. Right? What that means is it's the amperage times the minutes. That's the golden rule for iontophoresis, 40 milliamp minutes. So if you get any questions on iontophoresis and it's talking about the treatment, your goal is to get to 40 milliamp minutes. So if I have a time of 10 minutes, how many milliamps does it need to be?
4.
4. So it's literally just the time multiplied by the milliamps. Right?
I'm
So
sorry, Mr. McKeever, that doesn't make sense to me because when I multiply 40 times 10, that gives me 400.
4 milliamps times 10.
Oh, got it.
So we're always constantly going to be looking to whatever equals to 40.
Whatever equals to 40, yes. At least for your boards, Brooke.
Okay. What is iontophoresis again?
Okay, what is ionto? Good question.
It's when they put a medicine, like usually a liquid, in like an electropad, and it has the same ions, negative or positive, and so it pushes the medicine into your skin.
Right. And then if we use ultrasound, it's what?
Phono.
Oh no.
Phono. Yeah, right. So ionto, just remember that ion is electricity. Phono is sound. Right? That'll help you keep those two straight.
And is this where it has to deal with the cathode and anode?
Yep. Yes, it does. That was going to be my next question. We're going to get there in a second. Give me a second on that. But I want to really hit this 40 milliamp minute. So whatever you do, whatever your question is on iontophoresis, whether it talks about the milliamps or whether it talks about the minutes, you're always going to divide whatever number they have into 40 and figure out what's left. So if in this case it says, according to your treatment, your PT recommends 2 milliamps, how long would the treatment be for? "20 minutes. Good, Alex. Good. Does that make sense? 2 times 20, 40. Right? The difference when you're doing iontophoresis is the higher the milliamps, the greater the chance of a reaction. Because you're really driving a lot of electricity into that, and that could cause a burn or irritation. Right? Typically, it's 4 milliamps at 10 minutes is what most of the time we do. But if the patient, doesn't have a lot of time, we can up that milliamp, but the downside is they could get some irritation from it. So just remember, whatever you're doing, 40 is kind of the number you want to get to. And then I guarantee that's going to be the question for it. Now, as far as the charges, remember, like she was saying about anode and cathode, they're not going to ask you anode and cathode, just to let you calm down about that. They'll just say, in this case, you've got a negative ion, right? It says it has a negative charge. That means it goes under the same pad. So that it's in this case, it would say you're performing ionophoresis to the patient using acetic acid, which has a negative charge. Which pad would you place this under? And you would place it under the negative pad because you want to drive it into the skin, right? Same charges repel each other.
Is
Right.
the pad the anode?
Yes. Hold on, I've got to go through my head. So a cation ion is a positively charged ion that goes towards a negative cathode. Is that the way it works? And don't worry about the cathode and anode. I'm going to mess myself up on that one now. Or as just to let you know, or as a flat earther the other day when I was on a stream with one of them, cations and anions. He's like, you know, salt is a cation. What the hell is a cation? I realized you were saying cation ion. Cation. I loved it. Anyway, and then the others were anions. People are stupid. But yeah, so don't worry about necessarily cation. Yeah, exactly. Oh God, that's what I thought too. I'm like, what? Why are there cations in salt? But don't worry about Brooke. Yes, while there is anode, cathode, all that fun stuff, your boards are literally just going to say this is a negative charge solution. You're going to put it under what pad? Cathode is negative. Yes, you're right.
Okay, because I just got a
That means an anion is the negative charge. Thank you, Alex. I had to think about it for a little bit.
I got a question on one of the practice things about like what I can't like say it exactly, but it had to deal with you don't want to like burn the patient or something. So you increase what it says, like a bigger pad of the cathode, less or smaller pad of anode. It was something like that.
Yes. Okay. Good question. So, well, first of all, you'd have to determine which the medicine's going under. Right? Did the questions, because if the question didn't say that,
I don't remember.
And honestly, so most of the times for the board questions that I've seen, specifically on the PETs and also on the boards themselves, they'll just say you're delivering a negative charge medication, and it'll say whatever the medication is.
Mm-hmm.
And in order to avoid a burn at the location, you would use a larger positive pad, negative pad, right? Blah, blah, blah. The larger the pad for the medication, the less chance of a burn.
So it wouldn't be like, so since cathode is negative, anode is positive, you wouldn't increase the anode because more positive?
No, because it's not, your medicine's not going under that one. That one's just the dispersive pad. That's what's called the dispersive. It completes the circuit. That's all that does.
Okay, so you want to increase the pad that has the medicine on it.
Yes. Yep.
Okay.
Because think about it. So let's say I have a pad the size of my pen tip, right?
Mm-hmm.
And I put all the medication in that. And then my other pad's the size of my pad here. If I put all the same medication, all that medication is going in that little itsy bitsy area. That's going to be a high intensity negative charge, right? Versus this, which is now spread over a larger surface area. It's going to decrease the chance of the charge. Does that make sense?
Okay, so it's not necessarily following just the negative and positive.
No, it's more about where the medication kind of is, if that makes sense.
That makes
a little bit more sense, at least.
Yeah, now I know. Thank you.
Yeah. And so, and then let's say it's not even medication wise. It's now talking about high volt would be a great example of this, where we're doing it for wound care. And it says you want to decrease the chance of irritation at the location of whatever. You would increase both pad sizes, right? Because by increasing the pad size, you increase the charge going across a larger area. Does that make sense? Good. That was actually that was a good question. I figured you guys didn't get much about, yeah, what does it mean by the pH? For this question, the pH means nothing. Right? But what does pH mean? It just tells you if it's a what or a what.
Alkyne or acid.
Yeah, acid or base. That's it. Right? And I think lower than 7, I think 7 is neutral, or 8 is neutral, one of the two.
7.5 is like our bodies.
Yeah, 7.5 is our body. We're slightly acidic. Yeah, so it is 8 that's neutral. Thank you. We're slightly acidic. So, the lower the number, the more acidic, the higher the number, the more basic. Would you ever decrease the pad size? Good question, Brooke. And the only time I would decrease the pad size is if I was doing Russian and I couldn't isolate a specific muscle because I have, like, for example, in my extensor group, right? Because I have all those muscles laying over there, I may have to decrease the size just to hit a specific muscle. Or like if you're doing Russian to the patient's face, which would be just mean. And we used to do that all the time. I don't understand. Like, I don't know how patients didn't kill us. Does that help a little bit with those? Yeah. Okay. Couple more. Give me 1 second. Let's just change the name of my title. Okay. So, which of the following STM techniques is most appropriate for a patient in acute pain? Acute is your key word there, right? And pain. The best answer there is effleurage. Would we do some petrissage? Maybe. Right, but what's our goal if the patient's in acute pain? What is the pain control treatment method we want to hit? What are our 2 pain control methods that we have in the body? Gait control, yes, right? Gait. So we have gait and we have chronic opiate release, right? And effleurage is just rubbing, right? We're just do, feels good, makes them happy. So effleurage is that basic stroke that we start with. Petrissage, what are we going to use that for? Primarily? What do you think? Any idea?
I'm gonna be wrong, but I want to say lung percussion.
That would be tapotement. Yep. Okay, you're on the right path at least, Riley. Tapotement would be like the lung percussion. That'd be tapotement's the beating, right? Anytime you see the beating of any type, that's what your question is going to be on the board. Is tapotement would be for clearing the lungs, right?
Got it. So petrissage is kneading.
Kneading, yes. And so we'd want that to, okay, scar tissue would be used, which one?
Cross friction.
Cross friction. Good. Yep. And then petrissage would be to break up any adhesions, right? Because you're lifting up the tissue and kind of moving it around. Or just general, that's the most common massage. When you go to the massage clinic, that's most of what they do for you, right? They petrissage you. Unless you go to those special clinics, and we're not going to talk about those. There's a couple of those special clinics in Vegas. Anthony? No, just kidding. All right. I don't know if they're hiring. You mean, are you talking about trigger point, Alex? Not pressure point? Yeah, not necessarily. So kneading, I'm literally going to grab a hold. So petrissage, I'm literally going to grab that muscle and I'm going to lift it up. And it's basically like I'm making bread with the skin, right? Whereas trigger point, I'm going to find that spot, I'm going to press and I'm going to hold. Does that help? Trigger points is for, well, more importantly, trigger points is for trigger points. But yes, you could think of them as little knots because you thought they were something good, but they're not. All right. Next, you don't get on my bad jokes just because I have to quiz. there, that's uploading. That upload while I finish this with you guys. All right, good. Overall, good answer there, right? So in this case, the A delta is the best choice here, right? Do you guys remember much about this with the pain fibers?
Nope.
Okay. Nope, not at all. So here's the good news is you're not likely to get many questions on this, but I just wanted to see how much you remembered about these. So this would be one of those of you might get one question on it, if that makes sense, right? But it does fall under neuro, so you may get a question in the neuro section about it. So your A deltas are your small fibers, right? They're small fibers and they're myelinated. So that means what about their transmission?
Fast.
Fast, good, right? They're kind of your most what do you call it? The most sensitive. There we go. Because trying to think of the word. They're the most sensitive to stimuli, right? It's typically quick onset, short lasting, right? So you stub your toe. That is, you're more likely to stimulate A delta fibers, right? Because it hurts really bad, really fast. And thinking about it, are you likely to cry from that? Probably not. You're more likely to say some really bad words, right? Your C fibers are your other major nerves. Now, they are also small and unmyelinated, right? But they are your typical achy fibers, right? And the way I always remembered this is if I have a chronic pain, it's achy. So I've got my C fibers triggered. Does that make sense? They are I'm sorry, they're unmyelinated. Did I say that, Alex? I'm sorry. They're unmyelinated. I'm sorry if I said myelinated. I might have made a mistake.
Wait, is the first one's myelinated?
First one is myelinated. Your A deltas are myelinated. Your C's are unmyelinated.
Okay.
I apologize if I messed that up. My head was already going to the next section. So A delta's myelinated, quick action, which means the pain is going to relatively offset pretty quick. Does that make sense? Because the signal's going to go, the signal's going to come back. It's gone. And again, I think of the C fibers as my chronic fibers. Do you see how that kind of works out there? C fibers, they're longer lasting. They're unmyelinated. What about the signal? Is it going to be faster or slower?
Slow.
Slower, right? Because it's unmyelinated, right? It's typically a longer lasting pain. And usually those are the more emotionally hard to deal with pains, right? So low back pain would be a great example of a C fiber pain. Does that make sense?
Could do C fibers? This is just not really relevant to anything. Just the C fibers, can they like happen when you have a cold? You know how your body's like achy?
Yeah, I would bet if we checked, C fibers are probably active then. Yeah. I mean, I don't have like, what do you call it? I don't have research to say yes or no, Brooke, on that. But I would be willing to bet if we looked that C fibers are probably active during colds and flus and stuff like that, right? And it kind of makes sense because the other thing that C fibers cause us to do is sweat, nausea, increase our heart rate, increase our blood pressure, right? Which goes along with the cold, doesn't it? It's probably the body firing off those fibers so we stop moving and get better. Now, if I come up and flick you on the forehead, your A fiber is going to fire off, right? And I may get punched afterwards, but it'd be funny for the moment. And again, I didn't want to like kind of dwell on this too much. I just want to see if you guys could remember the difference between A delta and C fibers. The A beta and the A gamma are different nerve fibers. Don't worry about those. The two main ones you're going to get questions on are the A deltas and the C's. If you get a question on them, right? So and again, the way I always kind of remembered it was A delta is acute, C fiber chronic. It's not that way. It's not always that way, but that just kind of reminded me of the pain types. Does that make sense? Because my acute pain is going to be my sharper pain, shorter lasting. Chronic pain is going to be my dull, throbby, longer lasting pain. All right, we got like 2 more questions. I just realized I spelled one of those words wrong. Okay, so what is biofeedback, first of all?
Visual recognition of what their muscles are doing.
Yeah, it's just recognition of their muscles. It doesn't have to be visual yet, Riley, right? But it's just, you put pads on them, and when they fire the muscle, something happens that indicates the muscle's firing, right? It can be visual or it can be auditory, right? I'm glad none of you picked auditory or sound, because that would just be cruel and unusual punishment to a deaf patient, right? Do you hear it? Why not? Did you guys hear the joke about the deaf patient? Neither did he. That was bad, Mr. McKeever. Bad, Mr. McKeever. The blind person didn't see the joke either, but that's beside the point. Anyway, yeah, so we want visual. Now, I totally spelled nociceptive wrong. I just realized that. We could give you can use biofeedback and have it give a sensory feedback as well. And the way you do that is you kind of, it's not nociceptive, it's more along the lines of almost like a TENS feeling or an IFC feeling, that when they start firing, the pads tingle. There are certain biofeedbacks that cause the pads to tingle. And the more they fire, the more that tingle happens. So it indicates they're firing more frequently. But usually it's auditory and visual that are the feedback. And visual is usually this bar that goes across the screen or whatever it is, showing that they're firing harder. All right, we got one more. Here we go. Let's bring it home. It's not always visual, Riley, no. All right, so it's uploaded at least. Now I just gotta wait for it to get approved. Have I gotten any new followers? I'm stuck at 110 people on YouTube for like years. Come on, guys, I'm trying to get monetized here. I need 1,000 people to follow me on YouTube. Pimo would probably take the money. All right, what do we got here? Please tell me that's everyone. Is that everyone? Very good, right? Our 2 superior landmarks are the malleoli, right? We got the navicular tuberosity, and then what's the other one? We have one more landmark.
Calcaneus?
No. Let's see, not talus. Good guess though. So far we're going to good guesses.
The 5th metatarsal, what is it, protuberance or something like that?
Okay, it's off the 5th metatarsal. It's not the protuberance, it's the head.
Oh, okay.
Yeah, the 5th met head. Yeah, good. Right, but it's like it's not called, I forget, it's not protuberance. It's God, I can't think what it's not a tuberosity. There's some sort of a name for that one too, as well.
There is. I just say it protrudes out, so it's
yeah. Just remember, you're looking for the 5th met something, right? But the MTP joint definitely not. Right. So remember the bones of the foot. What's the first bone at the very top of the ankle? That's the talus, right? The talus forms the ankle mortise, right? And then we have our calcaneus, right? And then we have our what? Set. Navicular and cuboid, good, right? And then we have our 3 cuneiforms, right? Yes, remember, I always remember the Navy is the boat and it's floating in the seas, the cuboids. Good, good, good. Good job, guys. All right, let's see how we did here overall. Not bad. Not bad. Those are a little harder than could be, right? Let me exit out of my quiz. And again, oh, stop share. There we go. One thing to think about with this, I know other systems is there, and I know that's something that we get worried about. But remember that other systems is not going to be a major part of your test. Right? Other systems and non-systems, which I think is your review this week, if I remember correctly. And even research and all of that fun stuff is only about 20% of your test. While yes, 20% is big, it's still only 20%, right? Your neuro, your cardio, your musculoskeletal is the rest of the test. So just remember that you know, while you may have not done as well as you wanted to here, remember that's a small portion of the test compared to the bigger portion that you want, right? I mean, last week when we did the musculoskeletal review, you guys did really well. So that's a benefit. And then take a look at this, right? And the way I'd look at these over time is just kind of, I would be keeping track of what my scores are in each quiz and kind of adding them up and see where I'm at. Because that's where I'm getting again, 67% is what you want on the boards. And I'm trying to make these quizzes intentionally hard. I'm not going easy on you. These aren't questions I would put on a test for the newbies, right? I wouldn't put these questions on the test for the kids that right now, because they're already crying about lay, and lie for Dr. SoCal. But I make these intentionally hard. And the hardest question of that day was the one that I screwed up. So I got to go in and fix that one so it's the right answer. I can't believe I messed that up. That's hilarious. Let me quick fix that. The following is not a standard stage of feeling during cryotherapy. Edit that. How did I mess that up? There we go. I fixed it. I have to go in and make all the previous polls active again, because the way Slido works is they're active for 7 days. So every 7 days I have to go in and reactivate them so that you can go back and look at them. If you want to go back and look at the musculoskeletal, or if you want to go back and look at the other ones. So it's just in the process of reactivating them all again. It's really silly the way they do it, but I just don't argue. And it's just one of those days where you don't want to wake up. Just kidding. Any other questions? Yeah, I know, Brooke, I messed you up. I'm sorry. Brooke's like,
you have some questions, but
okay,
ask them whenever. I don't know if
it's fine right now. I'm good.
Okay. I had a convex and concave question again.
Okay.
I don't know why I got it wrong on one of a question.
Okay.
The score builders.
Okay.
But I didn't want to ruin it for everybody.
Oh, I mean, oh well. If you ruin it for everybody, you ruin it for everybody. That means everyone gets it right.
Okay. It says a patient who has greater trochanteric bursitis completes active range of motion exercise for hip flexion. What direction does the femoral head slide on the acetabulum during hip flexion? So I broke it down. I was like, okay, what is moving on what?
Okay.
So it is convex moving on concave.
Okay.
And convex glides and slides in the opposite direction.
Okay.
Broke it down. But then I don't know, I got it wrong. I said it slides anteriorly and superiorly on the acetabulum, but it slides posteriorly and inferiorly on the acetabulum.
Okay. So here's my hip, right? I'm just using this as a basic hip. And so here's my hip joint between my two fingers. This is my femur. This is my acetabulum, right? You got the first part of it correct. You got all of the figuring out that which was convex, which was concave, right? Is it open or closed kinetic chain that's going on?
I want to say open.
Yeah, it's open. Yeah, right. It is. Actually, I guess technically whatever. I can't exactly show it, but this is the idea, right? So when you're doing hip flexion, the bone is moving which way?
Towards my like abdomen.
Okay, right? Which is on the what side of your body?
Anterior.
Good. That means it is rolling or moving anteriorly, which means it's got to roll and glide
Posterior.
posterior.
So it's going to be the opposite of the direction it's going.
Yes, it's going to be the opposite direction the bone is going.
Okay, so same thing for shoulder flexion.
Mm-hmm.
The same thing. My bone is moving towards my body anteriorly, so it's moving, sliding and gliding posteriorly.
Yes. Right, and slightly inferiorly, but the more important part is that it's going posterior.
Posterior. Okay. And posteriorly and inferiorly, it's all going to be together like that.
Typically, yeah. Posterior and inferior, usually, so posterior and inferior move together, whereas anterior and superior are typically together.
Yes. Okay. All right.
Does that help a little bit?
Yeah.
It's just figuring out which way the bone's moving first. What else? You just got a little confused.
Okay. So hip extension would be superiorly and anteriorly.
Yes. Yep.
All right. And then I was gonna ask you if we can go over like the triangle thing. I remember. Sorry.
That's okay. Hello, doggy. Her doggy started attacking her. It wants love. Please check your. What am I checking my settings for? Whatever. We'll wait till she comes back. She started a question. Anyone else have any questions while we wait for her to come back?
I actually have a question.
No.
Oh, no,
Okay.
Jason, go ahead. Jason, go ahead.
I was gonna ask about, since we're speaking of mobs on the ankle.
Okay.
Dorsiflexion is posterior?
Yes. So the way to remember about most of joint mobs in general, that you're going to mob it in the opposite direction it's kind of going. So think about, here's my ankle,
Yeah.
right? When I dorsiflex, I'm going towards the front, if that makes sense.
Oh, you know what? Yeah, it does now. All right.
Okay.
I was reviewing some notes and I was like, why would it be posterior? Wouldn't it glide post? But I get it now. Okay.
Right. And whereas if I'm doing plantar flexion, I'm going back towards the posterior side. So you'd want to go
Yeah.
this way. For the most part, your joint mobs, that'd be the answer. There are some weird ones of the spine, but I don't think you guys should get spinal mobs. Your answer for spinal mobs is no.
So my question was, I had a practice test question about negative predictive value. Are we gonna get a question on that?
Is that on the PT final exam?
Yeah.
Yeah. Okay. Like I said, I think I mentioned at the very beginning, I don't like the way they word those questions. I think you just weren't here for and talk about it. And I think I'm going to be 100% honest. I really don't like their wording of those questions. And they're not worded the way the boards are worded. So the boards are going to be based upon spin and snout, like we've learned before. So, a high specificity rules it in, a high sensitivity rules it out. And like I think Jason asked about this earlier. So they'll give you a question like they'll say, the Thomas test has this specificity and this sensitivity is good at doing what? Ruling condition in or ruling condition out. Or it may say you're trying to rule a condition in, which of the following tests would be best, and you're going to go down and look for the highest specific test. So they'll give you the numbers and everything. You don't have to memorize the numbers either, so don't freak out about that.
Thank you.
Yeah. Yeah, and I've got to talk to them about that because I don't like I understand the way they're wording it, and they're wording it like a DPT would word it for research, but it's confusing. Yeah. Alex, I'll talk to you about that then. I got your text message. I'm responding to you today about that. So, and then Brooke, what was your final question? Or your question? Not your final, I'm sure.
I remember you saying something about, it was the triangle thing, and you drew this for us during school. And
The diamond of the pelvis?
Yes. And I don't know where I put that. And I was just thinking, I don't know, it could probably help me.
I will be glad. Let me get my whiteboard up here so I can draw. I need a new whiteboard. There we go. All right, so we got my whiteboard up here. Let's draw the diamond here. I'm impressed. I actually drew something fairly effectively. And then we'll get my pen out and we'll label this. There's my ASIS. There's my PS. Oh, there we go. Did it finally share finally, or somebody joining me? All right, so there's my PSIS. I need to bring up my chat just in case any of you ask questions. Give me a second. Let me get that up here. Y'all can see this so far. Yes, I assume. Okay. Here's my trunk. What the heck? And here's my legs. Let me make, I am sharing it, right? Yeah. Okay, y'all can still see it, yes?
Yeah, but it's like down to the right, so we can't see the legs or the PSIS.
Why is it doing this? Hold on here.
Oh, it's letting me draw on it.
Oh. Let me not let you guys draw on it. Because they're gonna mess me up. Oh, export. That's great. Viewer. There, now you guys can't. All right. Thanks, Jason. Appreciate that. Wait,
Oh, never mind. I just needed to scroll over. It's fine.
okay. So that's the basic layout of the diamond, right? So this is my anterior side. This is my post. Why does it keep going from full screen to? I don't know why mine keeps doing that. All right, so posterior side. So these muscles up here are my trunk flexors. And then these are my hip flexors. Does it keep going from full screen to non-full screen for everyone, or is it just me? It doesn't look like it's, oh, it is, okay. So what the heck is going on? Okay, stay full screen. I'm ordering you to. I don't. All right, hold on here. Let me try something. Share whiteboard. All right, I might have to redraw it here, but at least now it's full screen. Whatever. Redraw it here. Diamond. Diamond. What the heck? No, I want a new one. There we go. There's my diamond. Now let's do drawing. So ASIS. Trunk. And leg. So up here we have my trunk. Flexors. Hip flexors. Hip extensors. And my trunk extensors. I think my left mouse button is going bad on my mouse. Oh no. I have to go break out one of my other mice. So that's the general diamond itself, right? And the main thing you're going to have questions about this in general about will be when it's saying your patient has tight X, what rotation is the pelvis in, or what do you need to stretch or strengthen, right? So if I go into anterior pelvic tilt, where the ASIS goes down and the PSIS goes up, which muscles will get shorter?
Hip flexors and trunk extensors.
Yes, so these two will get shorter. And then by kind of process of elimination, the other two will be my lengthened ones, right? So that means I would need to stretch these, right? My trunk extensors and my hip flexors, and I would need to maybe strengthen the other two. That doesn't necessarily mean they're weak, but that could be an option I could do. So the question would say something like, your patient has excessive anterior pelvic tilt. Which of the following muscles would need stretched on this patient, right? And you'd be going either looking for one of your hip flexors or the whole hip flexor group, or one of the trunk extensors or one of the trunk extensor group, like erector spinae or iliopsoas or something like that. You would need either, rectus abdominis, internal obliques, anything like that, or my hamstrings or my glutes stretched. So now let's reverse that, take these off. And now let's go back to drawing here and go back to black. Now we go into posterior pelvic tilt. So now which muscles are tight in posterior pelvic tilt?
Is it the hamstrings or no?
The hamstrings, good, right? And then going along with the hamstrings would be the
Trunk flexors.
trunk flexors. Yeah, remember, it just goes opposite sides of the diamond. Good. And that means my long ones would be my other two. Now, most of the time, we want them to exercise into posterior pelvic tilt because we sit in anterior tilt, right? We almost always kind of sit, we get that rolled shoulder and the anterior tilt in our pelvis, we get that sway back going on. So we work on getting them in that flat back, right? Now, for comfort, you want a little bit of lumbar lordosis back there, but you don't want to look like your badonkadonk is poking out at the club. So if you're one of those people that goes to the club and has your badonkadonk poking out, you might have some problems with your muscles there. I'm just saying. Does that help, Brooke? That help you remember it?
Yes, I just totally forgot like what it was about.
Yeah, it was mainly about the tightness in that. So they may ask you which muscles need stretch, or they may say your patient has tight hip extensors. That means the patient is likely in which form of pelvic tilt?
Posterior.
Posterior pelvic tilt, yeah. Right? And for the most part, if you get a question about that, two of the other answers will be right lateral tilt and left lateral tilt. And you know to just rule those two out because those aren't the answer for that. Now, that is the diamond for front to back. Let me do the diamond for side to side really quick, just so that we can cover that as well. So I'm going to get my eraser out here. Because we have two diamonds. We have the front to back diamond and the side to side diamond. All right, draw. And so here we have my greater troch. And we'll call this my right greater troch. This is my left greater troch. And I could have left this as trunk and my legs, but trunk. Oh my God. Legs. So this is my left leg. This is my right leg. And this is now talking about lateral tilt, right? So we have the diamond for anterior posterior tilt, and then we have the diamond for lateral tilt. In the superior portion of the body, we have primarily the QLs, right? So we have my right QL and we have my left QL. And then down here, we have my right glute med and my left glute med. So this is talking, when I'm talking about whether the pelvis is tilted like this, right? When I'm going side to side. So if I have a left tilt, right? So if I get that left tilt going on and my pelvis tilts over this way, right? What muscles are going to be tight?
The left glute med.
Good. Left glute med. Good. Right? And so because that one goes there, guess what? The right QL goes with it. It's the same as the other same as the other diamond. It works on the opposite sides of the diamond, right? So if you think about it, when I've got that tilt like this, look at this side of my trunk, right? And then my leg is like dangling, so it's going to be stretched out. This is tight because it's holding me here, right? But this is stretched out.
I feel like this one's like easier to picture.
Yeah, it is. Just because you think more about, you can do this easier than doing pelvic tilt, right?
And you can also think like, I don't know, like a mom when she carries her baby, it's always like tighter on the side where she holds because she's like hiking her hip up.
Yep.
That's her QL. It's tight and stuff.
Thinking about being a mom here, I see. Not just kidding. So that's the two diamonds for the pelvis. That's the way I always remembered it. It helped me get through those questions. Does that help everybody a little bit? All right. Stop sharing this picture. Any other questions? If not, I'm good. Did we lose? No, Brooks. Okay. Is there anything else? If not, go forth, young children, and wreak havoc. I mean, have a good weekend. Stop recording.